Hi, everyone. Thanks for joining. I think we'll just give it another minute or two just before starting, just to give more people time to join. But thanks for turning up on time. Okay, maybe we'll get going. So first of all, thanks to all of you for dialing in on your Wednesday evening to join us for what is the second webinar in our FG Global series. Let me just get up the slides. So for those of you who didn't manage to join our first one, the premise of these is that we pick an amazing publication in frontline gastroenterology, and then we invite an international panel of experts, not just to discuss the paper itself, but some of the wider issues in the field. And the whole point here is that it's interactive, so we want you to post questions in the chat because we will put this to our panel at the end. So please do get involved and share your thoughts and questions with our panel. So in terms of your hosts, my name is Kohi Gananandan. I'm a registrar at the Royal London Hospital and an honorary research fellow with UCL.
Hi everyone, my name's Eathar Shakweh. I'm an IBD clinical research fellow based in London and a frontline gastroenterology trainee editor.
Hi everyone, I'm the third FG webinar trainee editor. I'm Irene Perez. I'm currently the Advanced Endoscopy Fellow at Moffitt Cancer Center and the University of Florida. Thank you so much for joining us today. We're excited you're here.
So fantastic. This is the webinar dream team. So we'll move on now, and this is what we're going to talk about today. So this is a fantastic paper that's been published by Prof McPherson and his team. And I'm sure most of you who are on this call are here because you're probably at least semi-interested in liver disease and probably aware of the admission bundle, which was produced before, but this has recently been updated and published in Frontline Gastroenterology. And just a shout out for this, we've also done a podcast on this, which is on the Frontline Gastroenterology kind of podcast streaming service. You can access this really on any of the platforms that you use to listen to your podcast, and is well worth a listen. And the final plug really just from a liver flavor is obviously with Basel coming up next week in Belfast. Hope to see many of you there. We have just as of today published a Basel special issue in Frontline Gastroenterology, which has lots of amazing liver related publications. So please do check it out. Just go on the Frontline website and you can see all the amazing papers there. So the outline of this webinar today is that we're just going to briefly discuss about the bundle and the updates. We're then going to move on to more talk about general acute decompensation management, which we know can be very tricky and complex. We'll then have a little summary, and then we'll move on to what's always a great bit of the webinar, which is the Q&A. So we have three excellent panel members with us today. Apologies that Prof Elliot Tapper is running slightly late, partly probably from my end, a timing issue with a calendar invite. So he is rapidly joining us within the next 10-15 minutes, but he will be here. But in the meantime, you have two other excellent members.
Great, thanks Kohi. So I'm delighted to introduce Professor Stuart McPherson, who's the first author of this exciting manuscript and a consultant hepatologist at the Liver Transplant Unit in Newcastle, and also honorary professor at Newcastle University. He's chaired multiple hepatology committees and is the vice president for hepatology of the BSG, and his main clinical interests include viral hepatitis, steatotic liver disease, cirrhosis, and liver transplant. Moving on to our next speaker.
So I have the pleasure of introducing Professor Elliot Tapper. He is academic chief and Andrews Family Research Professor of Hepatology at the University of Michigan. He is also editor-in-chief of Hepatology Communications and Cirrhosis Section Editor for Up to Date. He is widely known on social media as an educator, and his research focuses on the quality of life for patients with chronic liver disease.
And it's a great pleasure for me to finally introduce Salvatore Piano, who I've worked with personally as an excellent hepatologist. He's an associate professor of medicine and a consultant hepatologist in Padova. And you can see here, I mean, really needs no introductions, is on several committees and has editorial roles on several of the major liver journals. He was back in the day a rising easel star, and I think it's fair to say he's risen many years ago, and he's really one of the bright futures of hepatology. So really pleased to have him here, and his research interests really are in complications of liver disease, ACLF, and really renal dysfunction. So we really do have a fantastic panel with us.
Thank you. Hello, everybody, and thank you for inviting me.
All right, so let's talk about physical exam findings in patients with cirrhosis. So in the first image in figure 1A, you see spider angiomas, which are a collection of blood vessels that blanch when you press on the lesion and they refill when you let go of your finger. In patients with more advanced liver disease, you can see scleral icterus as shown in figure B, or jaundice. Patients with decompensated cirrhosis will have portal hypertension and therefore will have signs of volume overload on physical exam. And in figure C, you see ascites. So that's one of the things you can see. You can also see bilateral lower extremity edema, as well as hepatic encephalopathy, which manifests as asterixis on exam. Patients with decompensated cirrhosis are tenuous, and they can get sick very quickly. And you need to be aware of the type of decompensating events they can have and really appreciate how important timing of care is for these patients. Some of these patients may be liver transplant candidates. And so you do not want to miss the window of when these patients can get the transplant because you did not act fast enough. Unfortunately for these patients, when they present to the hospital, they can have a pretty high mortality rate of up to 20%. And since the COVID-19 pandemic, premature deaths from liver disease have also gone up by 20%. These are pretty striking numbers. And as clinicians, we need to acknowledge that patient outcomes for those with liver cirrhosis are not great in the UK. And we need to be motivated to improve those numbers and ultimately save the lives of patients with liver cirrhosis. So this updated decompensated cirrhosis care bundle is really designed for you to start it within the first 6 hours of when a patient presents to the hospital. It provides evidence-based recommendations for you to follow for the first 24 hours in the event that you may not have a hepatologist or a gastroenterologist available to you. These recommendations are very thoughtfully made. It was made by multiple specialists that included gastroenterologists, hepatologists, as well as acute medicine physicians from 3 national UK societies that included BSG, Basel, as well as Society of Acute Medicine. So in this slide, you see the schematic of the algorithm you're supposed to follow. And so this brings us to the first question. Professor McPherson, could you share with us why the original bundle was created and why this one was updated?
Yeah, thanks very much. So if we go back more than a decade, there was a real damning report in the UK called the NCPOD report that looked at deaths from people who died from alcohol-related disease. And they found that less than half of people who died had what was considered good care when their clinical history and management was looked at. So we really needed to do something to improve the care of patients with liver disease and decompensated liver disease. So the idea behind the bundle was to have a checklist simply to ensure that key investigations and management is conducted as soon as possible as someone comes through the door. Because as you've said, these patients are extremely complex. People admitting them are often quite junior and have limited experience. So we need to give them a clear and easy instructions on how to manage the patients. So over 10 years, evidence moves on, and it was definitely well overdue for an update. So we've got a great team together to review the evidence and come up with a new bundle, which was also meant to be a bit more user-friendly to try and improve utilization, because as we might discuss later on, we need to improve utilization of the bundle to improve outcomes.
Thank you, Professor McPherson. Dr. Piano, do you use bundles or something similar in your country of practice?
Unfortunately, in Italy, we don't have formal national cirrhosis care bundle. Of course, we have our internal protocols that incorporates most of the key steps that are recommended in the bundle you developed. However, I personally think that the structured bundle approach is a great strategy, especially for patients that are admitted in non-specialist units where the timely delivery of life-saving intervention for cirrhosis sometimes is delayed. And having this standardized checklist helps ensure that important measures are not missed and the care is more consistent across the different settings.
Thank you so much. We will move on to the next slide, please. So these are the specific changes made to this updated bundle. And I will ask Professor McPherson what process was taken to provide us with this update, and if you have any comments on the specific changes that were made.
Yeah, so we underwent a full evidence review of everything that was in the previous bundle and updated it accordingly. We graded the evidence. We had a great group of people who went through that. We came up with some audit standards to try and drive up the quality of care. These, as you can see on the slide, are some of the changes. It's probably worth just outlining them. So we added in lactate to the investigations, as that's an important investigation to identify tissue hypoperfusion and sepsis, etc. Alcohol was really unchanged, or alcohol management was unchanged. The infection section, we very much focus now on the management of SPP because we acknowledge that infections in acute admissions tend to be quite well managed, things like respiratory infections, urinary infections. So to make it more focused, we just kept to SPP. In terms of AKI, we'll talk more about this later, but we're now recommending crystalloid as the fluid of choice for resuscitation rather than albumin, and we'll discuss, as I say, the evidence for that later. For the GI bleeding section, the previous bundle had suggested correcting abnormal coagulation parameters in someone with bleeding, but evidence suggests that there's increased risk of harm by doing that. So with that routine correction of clotting parameters is now not recommended unless there's massive bleeding, and that needs to be considered on a case-by-case basis. Previously, we just mentioned terlipressin, but there are contraindications to that. So now we mention octreotide can be considered as an alternative. The encephalopathy section was unchanged. And another important addition was early referral to dietetics, because almost every decompensated cirrhotic patient is malnourished, sarcopenic, and has complex nutritional needs. So we need to get dietetics involved early. Many of them get refeeding syndrome, so we need to monitor for that and manage all of that. So that's a brief overview of the changes, and I'm sure we'll get to the nitty-gritty of some of these things shortly.
Thank you so much, Professor McPherson. I will now hand it off to Eathar.
Fantastic. Thank you, Irene. Thanks, everyone. So now we're going to move on to discuss the various themes that were outlined in the bundle, starting with infection. Now, we all know that infection is a common cause of decompensation, and the bundle nicely delineates the infections that should be pursued in the first 24 hours. Now, focusing on spontaneous bacterial peritonitis, we know that an acidic tap is mandated early in admission, but often this isn't always achieved. So I'm now going to pose a question to our panel, starting with Dr. Piano. Why do we think that acidic taps are deferred in clinical practice, and what strategies can we adopt to address this?
Well, I think that one of the reasons is that many clinicians worldwide still equate an elevated INR with an increased bleeding risk, and this is usually causing a delay in performing the tap. And I can say that we are putting a lot of efforts into teaching colleagues that hemostasis is rebalanced in patients with cirrhosis, also showing the evidence that is also included in the EASL guidelines about pre-procedure management of and bleeding risk. And we are actually teaching that INR does not predict procedural bleeding risk. I have to say that there is still a big elephant in the room here, that is the fear of legal consequences that several colleagues have. In fact, there are still a lot of local policies that still mandate plasma transfusion before invasive procedures. And therefore, what it happens that during the overnight shift, sometimes the paracentesis is delayed. We are working a lot. We are, increasing the timely tap, but this is still one of the high quality measures that are delayed.
Thank you so much for highlighting these important issues. And I completely agree. A key learning point for everybody in this call is that coagulopathy should not defer an acidic tap. Moving on to Professor Tapper, we'd be really interested for your insights as to why acidic taps may be delayed in clinical practice.
Dr. Piano hit the nail on the head that the main thing is the INR that's dissuading people, and the way forward for there will be a combination of education, rewriting local and national guidelines. But in addition, I think anything that can reduce the transaction costs of an additional procedure and wed it to culturally to the standard of care for patients like this is going to go a long way. So when you have a bundle, if that bundle is automatically printed, so for example, when a patient arrives in our emergency department, the triage nurse will print out orders in somebody's name. These are the things that need to be done. And if this bundle is followed and orders for the acidic fluid are there, it will trigger that. In addition, we have to train the frontline providers on how to quickly do a diagnostic paracentesis. And if we are there and we are present at the bedside and we show them that we're a part of the care team, that we're invested in their education and training, it will go a long way, making sure that they know that it's relatively quick and it's absolutely important as it can save lives.
Thank you so much. And our second question pertaining to systemic infection is, in what circumstances would the panel pursue antimicrobials, whether that's antibiotics or systemic antifungals, in a patient with decompensated cirrhosis?
Perhaps I can get this question. Usually we always do an extensive workup for infection at admission, including TAP, ascites, blood culture, urine culture. Then if the infection is confirmed, we start antibiotics, but there are still a group of people in which there is a high suspicion of sepsis. They have organ dysfunction, and usually in this kind of patients, we used to start empirical antibody treatment, but to reassess the indication for treatment after 48, 72 hours. And if there is no strong evidence of infection, we usually withdraw antibiotics. And regarding antifungal, usually this is fungal infections occur as nosocomial. There is almost no patients that is coming to the hospital from the community with a fungal infection. So usually we consider antifungal for those that have risk factors, so develop nosocomial infection, have a long stay, have a previous antibiotic treatment, are on treatment with steroids, have a central venous catheter, have a parenteral nutrition. So for those that have nosocomial infections and several risk factors, we usually start with the echinocandins, and we always test for beta-glucan for the negative predictive value. So in case we start echinocandins, and the beta-glucan is negative, we usually withdraw antifungal. Okay, and I think this is also recommended in your bundle I have seen. So the document is very clear. But I know, what about Elliot? What is your strategy?
Yeah, so I agree with your approach with the sequential use of antibiotics for people who are not responding and for people who have specific special risk factors. But in the setting of the initial evaluation and our approach to these patients, it is incumbent on us to make very simple and clear messages. Step one, make sure the paracentesis is done. Step two, make sure that antibiotics follow that paracentesis. And if we're not careful and we overcomplicate things, as one of the people in the question period has already raised, people will then just shoot first and ask questions later. Ordering large, broad spectrum antibiotics, saying, well, it is simpler to simply treat, muddying the picture, creating additional problems. We have to make sure that our message is very clear up front, and then allow us to sort out the details within the next 12 or 24 hours.
That sounds great. Prof. McPherson, any thoughts?
Yeah, entirely agree with approaches that have been suggested. In the UK, one of the issues is that I think resident doctors, particularly overnight, are unconfident, don't do the tap, and just hit them with antibiotics. And that, as has been said, is a problem, because then you're left, well, does this patient have SBP or not? And then they don't then benefit from other treatments like albumin, etc. So as Elliot said, we must educate people. It is an extremely straightforward procedure. I mean, you could argue that taking blood is harder because you've actually got to aim for that, whereas an acidic tap is, in some patients, you could throw the needle from the end of the ward and hit the right place. I mean, I'm being a bit flippant, but in reality, we must educate and encourage and emphasize that the risk of not doing a tap outweighs the risk of doing a tap for that individual patient.
That's brilliant. Thank you so much for your insights. We're now going to move on to discuss the next theme, which is AKI, and I'm going to hand over to Kohi.
Yeah, so fantastic. I had a question on the last topic, but I'll save it till the end. So perhaps, Prof. McPherson, this is the updated kind of algorithm for managing AKI and then kind of HRS AKI. Could you just briefly take us through it, and then perhaps I'll bring in the panel for some discussion about it?
Yeah, so again, trying to keep this simple. So AKI, the approach is, the majority of cases who come in with an AKI, it's for all the usual things that patients who are not liver patients would get: hypovolemia, sepsis, etc. So we're trying to encourage people to do the simple things well. So suspending diuretics, beta blockers, NSAIDs, nephrotoxic drugs, treating infections right from the word go. Obviously, in parallel, fluid resuscitating the patients. We're moving, as we've said, away from albumin to crystalloid in this section on the back of the Eathar study. Fluid resuscitate with boluses and careful reassessment of the patient to ensure that the fluid is going in at appropriate rate. Usually 1 to 2 liters of fluid will render somebody euvolemic, but needs regular reassessment. If despite someone being euvolemic, urine output is poor, progressively increasing creatinine, then we need to obviously consider other causes, ultrasound to rule out things like obstructive lesions, etc. But one of the changes compared to some of the other guidance around is to try and diagnose HRS early. So once somebody is fluid replete, and we think that HRS is the diagnosis, to initiate terlipressin and albumin to try and treat that earlier, rather than waiting the 48 hours that was advocated in previous guidance. And clearly, if people deteriorate further, then considering whether renal replacement therapy is indicated. And that does require some thought about the patient and their overall prognosis. And we can perhaps discuss indications for that later, but that's a brief overview of this. And I'd be interested to hear the thoughts from the others.
So that's great. Thank you very much. So perhaps I'll bring in Dr. Piano at this point, maybe for a bit of controversy, which would be nice. It always makes a webinar slightly more interesting. Salvatore, you guys have obviously done a lot of research in Italy about albumin, with a lot of amazing studies coming out there. What is your approach to kind of the filling of an initial patient with crystalloid versus albumin?
Yeah, I mean, I think that in this scenario, it depends a lot what is the clinical scenario, because if you have a patients that have tensor ascites, peripheral edema, and you have no clear evidence of, over the erusiresis because of an increase of diuretics, giving crystalloids may actually worsen fluid retention because these patients already have an avid sodium reabsorption. And there are really old studies showing that the administration of crystalloids in these patients may actually cause an avid sodium retention. With albumin, you may use a lower volume, and this may actually increase natriuresis. So this is our approach. However, for many patients that actually come to the hospital because they have diarrhea, an excessive lactose administration, they have a recent increase in diuretics, so have an overdiuresis, crystalloids remain a very good option that should be encouraged over albumin.
And
I have a...
sorry.
No, if you want to complete this albumin story, because I have another comment. No,
please go. Yes, please.
The comment is about the systematic withdrawal of beta blockers in these patients for those that are not hypotensive. You know, if you have patients with a AKI, with a mean arterial pressure above 70 millimeters of mercury, I think that we do not have this strong evidence that beta blockers should be withdrawn. You know, while for other indication, I fully agree. For these, I think there is not so much evidence. I don't know what the other things.
So that's an interesting separate. So perhaps, Prof. Tapper, I'll bring you in on maybe make a comment on that and the albumin versus crystalloid first. But please feel free to follow on to the beta blockers. And I think Prof. McPherson is waiting in the sidelines to make his rebuttal.
Yeah, skipping albumin is perhaps the spiciest element of this document, right? Because this is what we have been doing. And unfortunately, we've been doing it without much evidence base. And the truth is that it's spicy, but it's brave and also probably correct that the overall outcomes with respect to renal recovery are likely to be no different if you are treating volume depletion. And yes, if you give somebody 9 grams of sodium, there might be some cleanup to do afterwards, but the albumin is more likely to cause pulmonary edema if that person is overloaded. And if we're thinking about cardiac hemodynamics, I think it's reasonable to withhold beta blockers in the short term, but it's even more reasonable to think more mechanistically. And perhaps the next iteration of these guidelines will be driven by the underlying physiology, with an increased incorporation of things like point of care ultrasound, whereby there are some people with tensitis who probably don't need fluid at all, but instead need a paracentesis. Or because in America, our kidneys are built different, our hearts are a lot stiffer, they might need diuresis.
That's really helpful. I'm going to have to put it back to Prof. McPherson now, a lot for him to talk about, I'm sure.
We need to keep it simple. This document is for people at the front door who are non-specialists. So I think giving clear, simple instructions for the first 24 hours is critical. And then the specialist can come along and, if necessarily, overrule the suspension of the beta blocker once they've done their assessment. So I think that's the rationale was keep it simple at all costs. So that's where we are. And we would hope within 24 hours you'll have a gastroenterologist or hepatologist along who can then do some of the nuanced management, particularly making a diagnosis of hepatorenal syndrome, in which case then terlipressin, albumin would certainly be indicated in that situation with evidence behind that.
Fantastic and well diffused, a very diplomatic answer. So thank you very much. So perhaps just one more comment just about terlipressin. You mentioned about historically how we waited kind of 48 hours, but there's some data coming through suggesting we should be perhaps looking earlier at 24 hours, although there are some conflicting results. Perhaps I'll go back to you, Dr. Piano. What's your approach on when to introduce, how early you introduce terlipressin, and particularly what's your concern in fluid overloaded patients, which is often quite a significant amount of the cohort that we're seeing?
So regarding the early administration of terlipressin, sometimes we anticipate its administration 24 hours in those that are actually have a further increase in serum creatinine. I have to say that I would be very careful about the early administration of terlipressin, because, you know, Elliot mentioned pulmonary edema with albumin, but you know that after the publication of the confirmed trial, you know, terlipressin has several side effects. Therefore, if we do not establish clear, strong evidence-based criteria for assessing early response, there is the risk that many patients will be treated with terlipressin without having hepatorenal syndrome with potential risk. You know, I fully understand that. On the other hand, pushing on albumin with the patients that are volume repleted can actually cause volume overload. And in this regard, if you know, we usually either measure central venous pressure to assess volume overload, or we are doing point of care ultrasound with you know, the measurement of vena cava diameter and collapsibility index. And in case you know, either of central venous pressure above 12 millimeters of mercury, or an inferior vena cava above 2.1 centimeters with a collapsibility index below 20%, sorry, we withdraw albumin and we proceed just with terlipressin. And in some of these patients, we even use a small dose of furosemide. This is our experience, no evidence-based. Okay, this is just was protocolized in some of the clinical trial we did in this field. But it's what we do, you know. We need a lot of research in this study, but I agree with you that we need to make the things simple for the bundle. You know, this is very, very complex scenario, and I think this is quite reasonable. But Stuart, I want to ask, how do you assess the response at 6 or 12 hours?
When the patient is 6 or 12 hours, I think that's probably slightly too early. I think 24 hours onwards, because actually we don't want to give terlipressin too early if they're still underfilled. So the key thing is to fill them up first and then initiate it. So, I personally don't think that a general physician should be initiating terlipressin. I think that should be a specialist decision, because as you pointed out, there are a lot of nuances to this and potential harm to be caused by inappropriate use. So whilst this paper was largely about the bundle, we did feel that we got drawn into a few things that are past 24 hours onwards, and started to make comments on ongoing management. So that's a politician's answer. I haven't really answered it, have I? Yeah. But there you go.
Just in the interest of time, Prof. Tapper, unless you have anything burning to say, I'll move on to the next section. Perfect. So I'll bring back in Irene.
All right, let's jump into some variceal bleeding. Dr. Piano, what is your approach to the timing of endoscopic intervention? And is there a specific location within the hospital that you want to scope this patient? And what do you prefer in terms of intubation?
So several questions. So usually it depends on a lot on this is happening. You know, during the day, usually you are able to do an endoscopy, an upper endoscopy within 6 hours. If this is occurring during night, for many patients, 6 to 12 hours, it's okay, because with vasoconstrictor, with terlipressin, with volume resuscitation, actually you are able to control the bleeding while you are arranging, the scope. The issue is for patients that are presenting with hemorrhagic shock, or with severe hepatic encephalopathy, you have to intubate them, transfer to the intensive care unit, and arrange the endoscopy to control the bleeding as soon as possible. We usually prefer doing that if the patient is stable. We admit him to the ward, and then we arrange in the endoscopy room. But for those that are unstable, develop hepatic encephalopathy, there is the risk of aspiration. We intubate them, transfer to the ICU, and do the scope there.
Perfect. So next question. So terlipressin is the preferred vasoactive agent in the UK. However, octreotide is what's used in the States or in North America. So Professor Tapper, what are your thoughts on the optimal splanchnic vasoactive agent to use for a variceal bleed?
You know, I've heard tall tales of the magical effect of terlipressin in this context. And I'm sure that there's a patient for whom a fire hose bleed can be reduced with a more powerful vasoactive agent. But if it ain't broke, you don't need to fix it. And octreotide is working just fine for the vast majority of patients. And so there's a tachyphylaxis to this drug, but within the first 12 to 24 hours in which I'm planning on doing my endoscopy, and I'll add, if there's hematemesis, that patient's getting intubated. Dr. Piano, if we're on call, we're intubating that patient. And then I will ask for octreotide. And then I wouldn't want to rush it, so that I would give it some time to work and that there's less blood in the esophagus when I go down.
Well, thank you so much. I will hand it off to Kohi now.
So I think we're actually back to Eathar again.
Yeah, it is my turn.
You're back up. You're back up.
I'm back on. So we're going to talk about the very, very important question of treatment escalation, or what's known in the US as ICU transfer. So this is just an open question to our expert panel. What factors do you take into consideration when determining whether someone is for escalation to the ICU or ICU transfer versus the patients who would be more suitable to a palliative or ward-based approach?
This is a uniquely British question, right? So in the United States, the availability of ICU beds is orders of magnitude greater. And the gatekeeping of ICU beds for goals of care is almost never done, to the point where goals of care discussions are often deferred to the ICU team, to the patient's peril, and to the management of the patient, and for poor management of the patient. There's probably a middle ground between us. So virtually anybody who is crumping, who's getting sick, shocky, has organ dysfunction, is going to land in the ICU.
That's really interesting to hear. And that occurs irrespective of, the number of hospitalizations they've had, number of decompensations. They'll just go to the ICU.
Unless that person was seen by a truly spectacular hepatologist who happened to have a clear discussion of goals of care with the patient and their family far in advance, and it just so happened that they landed in the hospital with this acute decompensation, and you can enact that plan that was discussed ahead of time, that person is going to the ICU.
Fantastic learning. This is why FG Global is great. I'm going to pose the same question now to Dr. Piano and Prof. McPherson.
So we are not in US. We have a limited number of beds for the ICU. So we need to select carefully the patients. Usually in our practice, those with severe HE, they need to be intubated because to protect airways, or those with severe bleeding, or those with shock, or those with AKI that need continuous renal replacement therapy and transferred to the ICU. And of course, these patients should be potentially liver transplant candidates. So I'm not transferring to the ICU an 80 years old patient with cirrhosis, mild of 30, with variceal bleeding, HE, and 3 organ failures. Okay.
That's brilliant. Thank you. Prof. McPherson?
Yeah, similar. Certainly not everyone goes. It does depend which hospital you work in the UK. There's a big postcode lottery as to whether you get into ICUs. A lot of the specialist centres have good access. And if a patient comes in with an acutely reversible decompensation, then of course ITU is the best place for them. I think we are quite good at advanced care planning in some centres now. Certainly in my own unit, we have a palliative care team member on our ward rounds, and we try and have advanced care planning discussions early. And if they're on their 5th admission with the same and they carry on drinking alcohol and the prognosis is poor, then they wouldn't get admitted to ICU. I think the person that comes through the front door with an acute decompensation, it's easier to send them to ITU in some ways because you don't really know what's going on. We're much more careful about sending them in people who might have been on the ward for 2 weeks and declined, and really they've got progressive deterioration and their prognosis is poor, rather than acutely reversible situation. So some of those patients we would move to early palliation rather than sending them to ITU at that point in time.
That's really helpful. And what scoring systems, if any, do the panel use to stratify a patient's trajectory after they walk in through the front door, or perhaps don't walk in? Dr. Piano?
Yeah, so I mean, we have several scores that we use. We use the MELD sodium for prioritizing to liver transplantation, CLIF, CACLF, and CLIF organ failure score to assess ACLF. And there are different scenarios. For example, for patients with severe ACLF, 3 or more organ failures that is admitted to the ICU, we are using a lot the dynamics of these scores, the number of organ failures, and CLIF CACLF also for defining futility. So, and now, it makes easy because for a patient with CLIF CACLF above 70 after the first 5 to 7 days of admission to the ICU, the probability of survival is 0%. And usually this is a case in which we discuss with the family the de-escalation of supporting care. These are the main scores that I'm using, but yeah.
Yeah, I would say that within our hospital, the concept of the MELD score is fairly universal, including amongst people with no GI training. And it's a very good shorthand for understanding the severity of illness, even if it misses so many things. And I do think that while I don't need ACLF scores to inform my management, it's particularly useful when having family meetings or discussing prognosis with patients, because as you start to count off organ failures, you don't have to explain why someone meets circulatory organ failure. You can just tell them that all the various forms of organ failure or life support that they require, and as they add up, they understand intuitively what that means. So I think ACLF, it does obfuscate the situation to some degree, but from the perspective of a patient, it's really quite informative.
That's really helpful. So essentially provides an objective measure when speaking to patients, if you can, and family as well. Brilliant. So we're now going to move on to the next slide.
So just to bring it back to the bundle, just to save us plenty of time, because there's tons of questions coming in the Q&A. So one of the things, Prof. McPherson, that you've introduced, and we're not going to go through this, but this is the audit standards that we should be trying to aim when we kind of implement the bundle, so it can be reassessed through future kind of projects, which I think is a fantastic addition. This is a question I've asked you before, but I think it's important. We know that uptake of the bundle historically has not been optimal. How do we think moving forward we can increase uptake of it?
How's that to me? Is it? I'd almost put it to the others, because we've been trying for years to get people to use the bundle more. I mean, we've set these audit standards, which I think are fairly ambitious in the real world, but actually they should be done in patients. So I'd be interested to hear what the others think, to give us some new ideas.
Yeah, I think the first step is creating it. The second one is socializing it. And if you just give one presentation to trainees about it, then that's grossly inadequate. It has to be done at least annually, if not quarterly, to help people understand. But the reality is it will continue to gather dust. And you have to think through the human factors of implementation in order to make that optimal goal a reality. And in my hands, the way that we've done this is by leveraging the electronic health record, whereby when someone goes to care for a particular condition, it automatically prompts them with the order sets. So when you put in a diagnosis code for cirrhosis, there's an order set that's available. When you go to order an antibiotic to treat spontaneous bacterial peritonitis, you have to tell the computer why you're ordering the antibiotic, and then it will automatically ask you, do you want to give albumin with that? And so as you start to think through, well, what are the key, the sort of the key focal points of each of these conditions? If there's an order or a diagnosis code that's associated with it, it becomes an opportunity to present people with the lesser utilized elements.
I fully agree with Elliot that you know, you need the technology. So the electronic alarm is very easy. This should be adapted to the system, to the healthcare system. For example, so yeah, in my country, we are not putting in the system the code for the diagnosis, you know, when we are prescribing medicine, but for sure, improving, you know, the link between the coding of the diagnosis, so cirrhosis, decompensated cirrhosis, with the bundle that is electronic. You need to do this, and this would help applying it into clinical care. Because otherwise, just with education, it is unlikely to improve it so much. I think that you are struggling with the first bundle a lot, no, Stuart, just for implementing it into clinical care.
Yeah, we've had a lot of frustrations with this. I mean, the bundle was developed with good intentions. It was initially on paper, and actually, because back in the day, most people were on paper records rather than electronic records, and then there's been a gradual move to electronic records in the UK. And some of our systems are quite clunky, and as a result, the bundles and the order sets are not quite as functional as we would like. So we had one in our system that frankly was useless, but we've now got a new system that is working better. So I completely agree with having really good systems like Elliot was describing, and that's what we need. And there is work towards that. And the good news for people working in England is that there's the NHS England Liver Transformation Plan, that one of the objectives is to do this with good IT across all the systems. So I think that will have widespread benefits, hopefully over the next year or so as that gets rolled out. So fingers crossed.
Completely agree with what you've all said. Now I'm going to bring it on to the Q&A section, because it'll give us a good 10 minutes of Q&A, and we've got a lot of questions coming through. Perhaps I'll kickstart it off and let my other two co-hosts come involved afterwards. There's been a couple just about, you know, who should go to ITU. And I think probably it's important to say I've seen a couple saying, you know, people with ACLF with active alcohol use, should they be going to ITU? And feel free, you three are significantly more experienced than me, but I think you should not be blocking their entry to ITU just because they have active alcohol use. You should be looking at the other factors at play in terms of comorbidities, age, functional status, and they shouldn't be excluded based on that. And perhaps the second point that I could put towards the panel is questions have come up about liver transplantation. Now, in the UK, we're not transplanting people who are actively drinking alcohol, although I know in Europe and abroad, patients with alcohol-related hepatitis are being considered for transplant. But perhaps you could provide some guidance on when is the right time to refer these patients when they're presenting decompensated. I'll put it towards Prof. Tapper first.
Yeah. So, I think the decision to transplant somebody for acute alcohol-associated hepatitis is a tough one, and very few people, even in centers where we're doing that sort of transplant, will actually progress through it, and they will not progress through it because of psychosocial issues or because they get better. So I think a referral is not low value. When you have severe liver injury, a referral is without a doubt the right step. And we have to be humble, right? I once told a man who had a MELD of 40, a bilirubin of 40, and multiple organ failures that I told his father that he was most likely to die. It was the most certain I've ever been. And within a couple of months, his bilirubin was 0.4, and he continues to message me through the portal. And I tell him how wrong I was. We have to be a little bit humble about this and understand that that alcohol is a curse, but it is also a gift insofar as if you're able to link these people to effective supportive care, there's a very good chance that they're going to recover.
Yeah, I think that active alcohol consumption should not be criteria for not transferring a patient to the ICU. And we also have, a specific program for liver transplantation in alcohol-related hepatitis. Really, just 10 to 15% of patients with severe alcohol-related hepatitis are going on the liver transplant list and are transplanted. But these patients are doing very well after liver transplantation. They are going very, very well. And in an era when we are talking about, liver transplantation for colon liver cancer metastases, that these patients are recurring, everybody is recurring. So these patients actually may have an opportunity. Then, Elliot already introduced the big problem. If there are psychosocial issues, anyway, this cannot go further with liver transplantation, but I will give them a chance.
Perhaps the other thing, while the other two are just looking up questions, terlipressin for 2 different indications. I think we were very pro terlipressin back in the day, and I think now we're realizing that maybe there are some issues with it. So one comment from a HRS perspective, can I ask the panel what their approach is to boluses versus infusions of terlipressin? And the second question from a variceal bleeding perspective, are we using terlipressin too early? That we're seeing patients in A&E who present with a variceal bleed and be given 2 mg of terlipressin before they've even had a unit of blood or any kind of resuscitation. So perhaps comments on those 2 would be helpful. Dr. Piano.
For HRS-AKI, I have a conflict of interest because we developed the continuous infusion and we are actually implementing that in clinical practice, and it is quite tolerated by the patients. So we are doing that for HRS-AKI, but for bleeding, we are still using the boluses because the mechanism is different. You need for a patient with HRS-AKI, you want a stable effects in reducing splanchnic arterial vasodilation. For those that are bleeding, you want really rapid effects just to stop bleeding, because after a single boluses, many of them are actually, you are able to stop the bleeding just with a bolus of terlipressin.
Yeah, I would just say I buy the continuous infusion. It makes much more sense. The work from Piano or from Marie Sinclair and Adam Testro in Melbourne, these things are, it is clear that is superior. However, in the United States, almost all hospitals will follow the FDA label, which is that trial, for whatever reason, was done using boluses, and therefore we are held to that. And that trial was approved, it got the drug approved for the treatment of HRS. And unless your pharmacists are going to allow you to use it off-label, it would get me in a lot of trouble to use it in variceal bleeding. And so if I'm going to get into trouble using it, it's going to be for someone who's exsanguinating. And I haven't had to do that yet.
Great. I'm going to potentially actually continue the conversation about alcohol. So alcohol use disorder, it's incredibly important and possibly doesn't get the attention that it requires due to resources, certainly in the United Kingdom. I know some centres in the UK offer acamprosate. I'm interested to know what the panel's experience is in managing alcohol use disorder and what resources are available in your centres and in your regions.
Well, I'll get started by saying that we will routinely advocate to initiate therapy to treat alcohol use disorder in the hospital. And this includes behavioral interventions where we will give people iPads so that they can join Alcohol Anonymous or do other kinds of therapy while they are in the hospital bed recovering. 1. 2, we will initiate medications for alcohol use disorder, including acamprosate and naltrexone. And many of us prefer naltrexone, and some people, because they're on opioids, they will receive acamprosate. The key thing is that you're doing something, that you're initiating it while the patient is in your grasp, and you're not making the mistake of deferring that responsibility to somebody else down the road, hoping, praying that it will be started after discharge, when it often is not.
Agreed. It's inexcusable for a patient who comes in with alcohol use disorder to not see someone that knows what they're doing with regards to alcohol. So that must happen in every situation. And there is underuse of the likes of acamprosate. It's straightforward. It should be on an order set for these patients who come in along with their thiamine and everything else that they get. So we should be really active on this, because we know that abstinence from alcohol is the key predictor of outcomes, and everything else we do is largely a waste of time if they don't stay off the drink.
Fully agree. Same here. We have an alcohol addiction unit in the hospital. Therefore, the patients are always assessed before discharge. We usually also provide them with a list of all the Alcohol Anonymous that are available in in the region, with the contacts and suggesting to get contact before leaving the hospital. And I mean, this is the key. This is probably the most effective measure for this patient.
Thank you very much.
I think we'll bring it to a close, but just there's two questions about one thing which we didn't touch on with variceal bleeding, which is clotting parameters. And I think we all have cases of anaesthetists. Often once we take someone to intensive care or to theatres, that we lose control over the resuscitation of a patient. And Dr. Patch always says this to us as trainees coming through. And actually, before you know it, 4 FFP have gone in, lots of various other blood products. And I think there's data coming through showing, that it can increase portal pressures. So is everyone moving towards using some kind of thromboelastic, whether it's a TEG, a ROTEM, some kind of equivalent to guide their product replacement in these scenarios? Or is there a room just for using conventional clotting parameters?
Thromboelastography presupposes that you understand how to interpret it, and virtually nobody who orders it can. And sometimes I'll get the result and I'll say it's normal, and I'll just move on with the right thing to do, because that person who is bleeding has a deficiency not in clotting proteins but in rubber bands, and that's how you stop a bleed. So what I do, my practice, is to show up at the bedside and swat away the FFP. And if you are present and you're not just dictating care from your couch, then you are much more likely to be able to persuade people. Now, it's a different battle sometimes, depending on how on the culture. If it's I do have some arguments with anesthesiologists along these lines, but if you cannot have this argument over the phone, it has to be in person. And ultimately, I'll make a deal. And the deal will always err towards reduced volume overall.
I think that's probably perfect. I'm sure the other two probably won't necessarily disagree with that. If they do, please speak now. But otherwise, I think we'll probably draw the webinar to a close, just because it's coming up to an hour now. So just last couple of things just to say to you all before you dash off to dinner or to bed. This is we just want to do a plug for the Evade project. So this is Torch, which I'm sure you're all aware of, is the national hepatology trainee network across the UK. And on the theme of bundles, our next project is going to be looking at the discharge bundle and looking at particularly the 3 months post admission with acute decompensation, how the outcomes of our patients do, and particularly looking at regional variations. So this is the time for all of you to join at all of your hospitals across the country. You can scan that QR code, you can email us, contact us. We want as many sites as possible, as many DGHs, as many tertiary centres as possible to give a really good picture of what we're doing in the UK and what we can do better. I'll hand over to Eathar.
Thanks, Kohi. At this point, we'd like to say a huge thank you to all of our expert panelists, to Frontline Gastroenterology Journal, to the BSG, to Basel, and of course to the Society of Acute Medicine as well. And we'd like to mention a special thanks to Editor-in-Chief, Dr. Phil Smith, for being an incredible mentor to us, and Dr. Aditi Kumar and Dr. Oliver Tabby, who are our associate editors. Thank you very much. We do want to make you aware that there is a CPD point available for this webinar, and this webinar will also be available to watch online on our YouTube channel. So please do tune in and let your colleagues know about that. And finally, we would be incredibly grateful for any feedback. This is an ongoing webinar series. So if you can take an opportunity just now to scan the QR code and deliver some feedback so that we can continue to deliver high impact, high quality content for you. Thank you very much.
One more, Eathar. So the last thing is just to save the date. This will be the next webinar that we're doing December 9th. All of you put it in your diary, including Prof Tapper and Dr. Piano. catchy title came up by Eathar and Irene. I take no credit. Scalpels, suturing, or syringes, the future of obesity care. We'll have a wide spectrum of bariatric surgeons, endoscopists, gastroenterologists there to debate this very contentious issue. So please don't miss out. Very topical with the Christmas turkey coming up. Thank you all. Thanks all for joining. Have a good evening, everyone.
Thank you, everyone. Bye.
Thank you. Bye-bye.
Bye.